Hello, this is Dr. Betty Rabinowitz, NextGen Healthcare's Chief Medical Officer and Principal with NextGen Advisors. I'd like to welcome you to our podcast, and as usual, today I'm joined by colleagues Graham Brown and Dr. Marty Lustig. Welcome, Graham, and welcome, Marty.
Thanks, Betty. Nice to be with you.
Thank you. It's great to be here.
So, just this week, the United States passed a grim milestone with deaths of Americans from COVID surpassing American deaths from the Spanish flu, the deadly influenza pandemic that spanned about 2 years from 1918. It really brought back kind of reflections and thoughts about that historical pandemic. And I wonder, in your minds, Graham, maybe you go first, what are some of the similarities and notable differences between these two pandemics?
On the similarities side, Betty, you just noted the absolute number of deaths from the 1918 pandemic is about the same as those who have passed away due to COVID. But what's changed, of course, is the size of the population of the United States in that time, where we have triple the number of people living in the United States than were 100 years ago. And so the absolute number of people that have become ill and died from this is dramatic and a large number. But as a percentage of the population, it's actually considerably smaller. And part of probably what's helped influence and mitigated the volume of deaths are a number of different advancements that come to mind for me in terms of medical technology and how we responded to this pandemic. So the ability to rapidly create tests that identify the presence of the virus, to roll those out while it was problematic a year ago, it still happened pretty fast. And there's, been the development of rapid antigen tests, as well as the evolution of PCR tests and rapid antigen tests. We've also put in place contact tracing systems. Those haven't been broadly implemented, but nonetheless, where they have put in place, it's really easy to identify clusters and to warn and advise people who may have come into contact with someone who's infected and help prevent further infection. Then there's a whole variety of treatments with regard to managing and lessening the impact of the illness. Our hospital infrastructure, our ICUs, our ability to intubate patients, to maintain them on artificial life support, to provide them with monoclonal antibody treatment. All of those things weren't available 100 years ago. So our ability to save people from a very dramatic illness has certainly evolved. And then, of course, the vaccines. The rapid development of vaccines that came to market within a matter of months and were available for testing and evaluation as to their efficacy certainly brought a huge amount of relief to those that were suffering and preventing further spread. I guess the final thing to note here is our technology in terms of our communication with each other has also just taken on a totally different world that would not have been anticipated or even foreseen 100 years ago. So that's allowed us to share information and knowledge at a global level. But it's also perpetuated a system of misinformation and sharing of misinformation at a global level that certainly prevented us from responding and acting always in our best interests.
Yeah, I think an interesting example of misinformation then and now, I mean, you speak to how social media has made it difficult to separate the wheat from the chaff, but the Spanish flu is called the Spanish flu because Spain was the only country that was transparent about what was going on there. So everybody decided, because that's what they were hearing, that that's where it came from, even though it didn't. And so there was a lot of misinformation in the Spanish flu pandemic, just like there's a lot of information today, even though there was no global infrastructure back then.
And it's interesting from a historical perspective as well. International travel is much more frequent and immediate and instant these days. So the spread of the pandemic was fast, rapid, could be tracked quickly, and was all over the world in no time. The combination of the movement of troops from the United States to Europe likely acted in that regard similar to the kind of travel that's now everywhere. Had it started, and there probably were flu outbreaks of more aggressive virus, more virulent strains, in the absence of large movements of humans, those probably never developed a pandemic. So it was kind of the combination of something that now is just prevalent, which is people get on planes and within no time it's all over the world. I remember us reviewing at the time the graph of the flights out of Wuhan, China, to all over the world, and the timetable around that, and each of those places where a plane went had an index case very quickly.
Along those lines, Betty, also the flu pandemic came in waves also, but they were slower. There was more space between the waves, probably related somewhat to what you're describing in terms of the travel back then compared to now, although there's also flu is more seasonal than COVID appears to be, but we're seeing the same kind of waves. And I think it's important to remind ourselves here that the flu pandemic lasted several years, and we don't know how long this one's going to last.
That's correct. The encouraging thing about the flu pandemic is that it eventually receded on its own. Either the virus mutated to a more friendly spot, or there was herd immunity in enough spots where it was kind of stopped in its tracks. Reflect for a moment. Graham, you mentioned the vaccine as such a differentiator from the previous historical pandemic. The number of 5 billion doses of vaccine that's been given across the world. Reflect on that achievement or milestone.
I think it's a massive achievement for the human race and for the development of science and technology to know that that milestone has been achieved within a year, right? I mean, it was just over a year ago that these were first coming out of clinical trials, and that we saw that there was efficacy being demonstrated, and they were moving more broadly into testing on different populations to scale up and grow. So the 5 billion doses administered is an enormous number. It doesn't obviously reflect the need in disseminating vaccines around the parts of the world that haven't as yet had access to them through lack of availability, lack of purchasing power, lack of authority to kind of get in queue and get access to these vaccines. And the disparity that exists from my perspective in terms of where vaccines are manufactured and by whom, and how rapidly they can get to the target populations because of how things have been aligned in the purchasing of those.
Mm-hmm. Absolutely. Marty, in view of kind of 5 billion doses provided, talk a little bit about your sense of the risk and safety record of these vaccines.
Yeah, it's actually, I've been reviewing some of the numbers recently. As you know, I love numbers, and it's actually quite remarkable. Though minor side effects from the vaccine are fairly common in terms of injection site pain or headaches or fever for 24 hours. But the serious side effects, the most recent data I looked at is about 1 per 100,000 doses. And if in serious side effects means, in the majority of those are severe allergic reactions, which of course are treatable and not life-threatening as long as there's the right services and technology available. Deaths from the vaccine are really, from what we know today, a small handful out of those 5 billion doses. Really the only ones where there's good evidence of a true causal relationship is in the young women, a few young women who have died from blood clots. And we've actually learned from that there's a specific antibody abnormality that those women have that you can actually test for before you give the vaccine. So now that we understand it better, those are preventable side effects. So it's extraordinarily safe.
Mm-hmm. And those specifically were with the non-messenger RNA vaccine, or were those in the messenger RNA as well?
I think there were some cases in both, but the non-messenger RNA is where there's considered a higher risk.
So considering that this is a enormously safe and effective vaccine. Why do you think we have been seeing so much vaccine hesitancy across the world? You know, this is almost it's not unique to us. It's a phenomenon that we are seeing everywhere the vaccine is being offered.
Right. So I didn't mention, the comparison of, 1 in 100,000 serious side effects versus almost 900 hospitalizations per 100,000 among people who get COVID, and in 200 deaths. So there's orders of magnitude difference in the risk of the vaccine versus the illness, and yet, as you say, we still are seeing hesitancy. And I'm sure both of you have opinions on this as well, but I think the politicization of the pandemic has been a problem, and part of what's gone along with that is a communication challenge. Graham mentioned earlier about the internet and social media and the difficulty of getting truth through all of the noise that's in there. And I think the politicization of this has actually just exacerbated that problem, so that it's hard for people to know what to believe. And if you take underneath that a sort of underlying distrust of authority and of science and past experience of some populations, you look at the African American population in the United States that have already an underlying historical legitimate fear of these kinds of new technologies that the government is sponsoring, so to speak. So I think all those issues play into how rational people can be hesitant about this.
Yeah, I totally agree. I think the only thing I would add to what Marty just said is I think there's been a real struggle from U.S. and global health agencies to maintain consistency of messaging. So much has evolved in our knowledge of COVID since it first came about a year and a half ago till now, that we've learned more about the disease, how it spreads. We're understanding different variants, but only learning in time whether those variants are more virulent or just more transmissible. And so the anxiety and our rapid ability to share information globally, there's a new report out, everyone learns about it, hears about it, but they interpret it in different ways. They interpret it from their own biases and their own perspectives. And that flood of new information that's not kind of curated and messaged and carefully controlled is leading to a place where people can draw from that what they want to reinforce the conclusions and the biases they already have around vaccines. And so I think that our ability to rapidly communicate and disseminate information in some ways becoming a barrier to our ability to clearly communicate and manage messaging in a way that would be more beneficial.
I also think there's a confusion that people get in understanding the individual risk benefit for them alongside of the risk benefit from a public health point of view, and that there's value in both of those realms. The value equations may be slightly different on someone's individual circumstances, but people, I think, have a really hard time wrapping their mind around both of those things at once and trying to figure out where they belong in that.
Absolutely. I think additionally, something about the speed at which the vaccine was developed and became available. I think people didn't know that messenger RNA technology was being worked on for 10, 15 years or more before, and that it was a historical coincidence that as messenger RNA came of age, came this enormous need for it. So it's almost, it felt to people experimental. It felt as if it didn't get tested enough. And I think there was not enough emphasis on the value of 5 billion, from a biological perspective, 5 billion shots in populations of a variety of kinds, highly heterogeneous, all ages, all, both genders, etc., mitigates for the shortness of the experience with it because of the volume of experience with it. And I think that concept wasn't emphasized. Clearly, people have said, if this was around longer, I have always taken vaccines. If this was around longer, I would have gotten this. And we didn't have time for longer. This was a place where people needed to clearly make a little bit of a leap of faith and weigh the numbers you provided, Marty, are staggering, the difference between the risk of COVID and the risk of the vaccine. But people don't really think of it in those terms.
An interesting example to me of the communication challenge is all the stuff we're seeing in the news now with healthcare workers protesting the mandatory vaccination, and people looking at that and saying, well, if healthcare workers don't want to get vaccinated, they must know something I don't know. And yet, even as early as the beginning of June, an AMA survey of physicians showed that 96% of physicians in the United States had been fully vaccinated by June. So there are a lot of healthcare workers who aren't necessarily health literate. And so just because they're healthcare workers doesn't mean that they understand the science. And yet, if you look at the physicians who I would expect to understand it, they're overwhelmingly getting vaccinated. And yet nobody talks about that. They talk about the protests they see on TV.
And also the aggregate number, because there's groups of healthcare workers who haven't gotten vaccinated, people are misinformed with an average number of healthcare workers, which is really it's not the way to look at it. Marty, can you talk a little bit about the special challenges and consideration for COVID vaccine in children?
Sure. I would just sort of highlight two things. One is people have questioned why it's taking so long, although we did just obviously hear about the approval for 5 to 11-year-olds. There are challenges both logistically and scientifically with moving the vaccine into the younger child populations. Knowing how to dose, whether it's done by weight or by age, and looking at both safety and efficacy in both of those parameters just takes a whole lot more time than you can do in an adult population. There are also, in the United States, there are regulatory differences. They require 4 to 6 months of follow-up for side effects in childhood vaccines compared to only 2 months with adults. So there's just differences in the development that require more time. The other issue is that we know that children are at lower risk of severe illness from the disease. So there's this question about should they still be getting it? And so as an example, if you look at the numbers in the United States, the hospitalization rate and death rates for children are much lower than for adults. So the death rate is about 12 deaths per 100,000. That's still 10 times the complication rate of the vaccine, but it's not as dramatic as what we see in adults where there's 200 deaths per 100,000. So it's a slightly different equation at the individual level, although still I would argue, given that we're seeing 250,000 children hospitalized per week over the last month with the Delta variant, that we should still be aggressively moving toward vaccinating kids, even with those less dramatic numbers. So, there are some differences there, but the risk to children is not de minimis. And by the way, they also are vectors for spreading it to at-risk adults. So there's a clear public health reason as well to vaccinate kids.
Absolutely. I wish we had more time to explore some more of these topics further, but our time is up today. Thank you, our listeners, for joining us today. I'd also like to thank my colleagues, Dr. Marty Lustig and Graham Brown, for sharing their insights and perspective. And if you've enjoyed today's topic, consider subscribing to our podcast. This is Dr. Betty Rubinowitz with NextGen Healthcare. Have a great day.